So this is a 69-year-old male with history of GI bleeding. He recently had a stroke last month with vision loss while he was off of his blood thinner. He has a past medical history of mitral valve repair in 2018, history of congenital pyloric stenosis. He underwent bowel surgery, and he's had prior stroke in 2022 with right-sided weakness. So in February, he presented with acute GI bleeding and was taken off of Eliquis and was placed just on aspirin. So in March, he presented with acute vision loss and was found to have a new stroke. So Plavix was added. And so the patient's been on aspirin and Plavix. CTA was performed and it confirmed that the appendage was not surgically ligated and there's no evidence of thrombus in the appendage. The echo showed that he has normal LV function and no significant valvular disease. So I'm going to take you to Dr. Gabriel, who's going to show you the TE images from today.
Hi everybody. Yeah, we're about to cross the septum here. We're looking for a posterior and
so we are about to do the, yes. So Gabriel, you want to show the pictures of the septum?
Yeah, we're right there.
So I'm using a BRK needle. I've got a venous axis, and I'm quite low on the septum, and I think I'm quite posterior. What do you like? I think it's a good position, right?
Yeah, you're as posterior as you can be, it looks like, in the right
so
image.
I like to do a low and posterior puncture. So can you get the Bovie, please? Can you apply the Bovie energy? So I usually use the Bovie. Yes, go ahead. And I'm just going to gradually advance the needle through. And I think I'm through.
And you're through there?
Right across.
Yes.
And just give the heparin now. What's his weight like? So let's give him about 7,000 of heparin. 7,000. So I've advanced the transeptal sheath inside. So make echo large and fluoro small, or make us small. Make,
that's probably good enough there.
Can you hear us? Can you switch the order to make echo big? Whoever's in the camera sorting it out, can you make echo big? That's good. Make fluoro and me less, smaller, and then the fluoro also on the side.
There you see the tip of his catheter. He's going to be pretty close to that left pulmonary vein.
Left corner, please. Fluoro also, please. Okay. So we're advancing a wire inside the left atrium, but I really need to show fluoro, please. Okay, you can show us only in one person. Yes, okay, that's great. So the first thing is we are going to measure left atrial pressure. And
Jose, can you get Sugemadex ready, please?
So the left atrial pressure is about 4. So give some additional fluid to 7.
Yeah, I've given him almost a liter so far.
So he's given an additional fluid because if we measure the left atrium with this pressure, it's not good. So we're going to actually increase the left atrial pressure. Otherwise, we tend to undersize the appendage, which we don't want. So I'm just going to make a little better view there, magnify it a little bit more so they can see it. That's good. So now I've got a transeptal sheath inside the left atrium, and I'm actually going inside with a super stiff wire into the pulmonary vein. So now we're in the pulmonary vein. I'm going to take out the sheath.
You see him go entering there on echo as well. Yep.
14 French single curve Watchman sheath in the left atrial. Let's just take that out, Ralph. So Gabe, do you want to show us some of the
yeah, sure.
appendages?
We took some measurements of the appendage here.
So Gabriel, you can show us some of the images of the
okay, yep. So this is our 0 degree. We've got a maximum width at the base of about 18, and that's about the max we get throughout. This is your 0 and 90 X-planed.
Can you speak a bit
we don't
louder?
We don't see any clot there.
Yep. I would actually measure it slightly higher up.
Yeah.
So bring it higher.
And then these
up.
are multi-view shots. We use 3D to get some MPR measurements here. And there you see the 0 and 90 there. And if you take these planes here, sorry, 1 second. There we go. Oh, that's because it's a stored image.
All right, we're going to advance the sheath inside into the left atrial appendage. And now we're going to get the dilator out, keeping the wire intact.
So again, that's our 45 and our 135. So if you take your planes here,
I think you're a bit low. I think your measurement should be a bit higher up. So we've got the
then you
sheath
get your
inside.
0 and your 90. Yeah.
Ryan, what do you think? Ryan? Okay.
Got two measurements at like 17, but that 20 is wrong.
Pigtail, please.
That's, I think, higher than where we're at, actually.
So we're getting the pigtail catheter inside the sheath, and then I'll retract the sheath and the pigtail together and advance it into the left atrial appendage. So I think you could have gone a tiny bit higher in your measurements, but it's okay.
Are you talking to me, Saibal? Or
yeah, I'm talking to you.
Move the blue line up a little bit?
A little bit higher, yeah.
Yeah.
Oh, yes, thank you. Yeah, a little bit higher up. The blue.
Higher up here?
Yeah. Okay. So now we've got the pigtail inside, and now just come out. And we're going to now advance.
That's 19 there.
Ralph? Yeah, it's okay.
And that 90 is our biggest at 19. I think a 24 is the right size for him. But.
Okay. So I'm going to now. Can you show me the short axis?
Yeah.
Live, and with the help of echo and fluoro, I'm going to go inside the atrial appendage. So I'm pulling back the catheter, and you'll see slowly I'm retracting back, just a little bit more.
Saibal, you want to do this in 2D or X-plane or
no, it's
or
okay. 135.
MPR?
For 45 is great.
Okay.
Can you find the sheath for me?
There you are.
Show me that. Is that going posteriorly?
I think you're getting hung up on the Coumadin ridge there. I think you need to pull back a little bit more.
Yeah, that's right. I got to pull it back a little bit more.
There you go. Now you're clear. Good. Perfect.
Right.
And you're in.
Now
Nice
I'm in
job.
the appendage. And now let's go to RAO 20. So we're going to go about RAO 20 and caudal 20. And let me see. Like that. Can you collimate a little bit? Yeah. All right. Ralph, be ready for injection. So now I'm going to do an angiogram of the appendage. Okay. So you see that the sheath is not. I'm going to try to put the sheath into the anterior lobe. By what I'm doing is I'm going to counterclockwise the sheath a little bit. Test.
Very good. You're in there. Nice.
That's in a nice position.
Mm-hmm.
And I'm going to do an angiogram. Inject hard. Good. Yeah, I was actually thinking bigger, you guys. I would measure the 135 real life because I think it's go higher up. And I would measure it again because I'm thinking of using a 27. So let's get a better measurement. You see, we usually like to measure accurately and go up there, not so high there, just the circumflex.
Right
That's
there,
right.
yep.
And then go up higher there, yes, and measure that. That's actually quite good. Very good. And remeasure the 135.
So here's the 45 just for reference.
18.2.
Yep. That's been pretty consistent.
Yep. So
20. Yeah. Okay. Fair enough.
So 21, basically 21.
And if you look here in the bottom left image, you see the cross section of the base.
Yeah. You want to show that measure, make the largest measurement over there?
So see, this is see where his catheter is. That's the anterior lobe right there, right? So more posterior there. And if you want to measure, you can see the biggest we get it. It's probably something like that.
Yes.
23, maybe.
Almost
even.
23. So the 23 means at least I have to use a 27 at 4. So So based on your measurements, I definitely have to. This is the advantage of MPR. And
Yeah,
you
we
can
didn't see this in 2D, you know?
You wouldn't get this in 2D. So I would definitely, it's a shallow appendage, which makes it very challenging. And what we do in our case is we do not do pre-imaging before. We bring them on the table and we decide on the table. So 27. Ralph, you take it?
And again, I'll show this again. So we have our 0 and 135 here. So that green line produces the 0.
So why don't you make the red line?
And then now if we want to make a...
bring the red line into the maximum.
I'm sorry, 45 and 135 is what I meant to say. And now you have a 0 and a 90 right there.
No, I would make the 0 the largest diameter.
This is the 0 right here, right? You see aorta flush there.
And bring it down. I think the blue line's a bit too high.
Well, see, that's the advantage of this, right? Because when we were measuring our 45 and 135, that was like this, right?
Yes.
And you said that was the level you wanted it to be at, and that blue line doesn't change. Do you understand what I'm saying? Yeah.
Yes. But I
do agree that here in the 0, it looks like that looks fine, but this looks high, right?
Yes.
Like you would probably implant it down here, tilted this way, right?
That's too low.
That's too low. So a little higher then, huh?
Just tell them. All right. So we're ready to advance the device. We decided to use a 27 Watchman Flex. Let him prep it here. Bring it here. Bring it here. Don't do it there. All right. Attach it to the flush, please.
So I went back to the 45 and 135 there.
Yeah.
And just get our image and we're there.
Yeah. Okay, good. So is he de-aired it? Yeah. So we're de-airing the device. And notice that I've kept the pigtail catheter still in the left atrial appendage. Yeah, flushing. He's flushing this thing. That's good. And I'm just going to do one more contrast. Okay, it hasn't gone too deep. Now I remove the pigtail catheter. And once I remove the pigtail catheter, to be very careful the sheet without the pigtail inside. So I'm just keeping. And now start giving contrast. Stop flushing. And I'm advancing the device slowly. As you can see, it's going right inside the left atrial appendage, right over there. And now small test. Okay, more. Small test again. Good. So we're quite deep inside the appendage. I don't think we can go any deeper, right? But since we don't have much of depth, we have to start deploying from there. So we're in the anterior lobe. And the first thing as I create a ball.
You can see the ball in the bottom left.
Yeah, bottom
showing.
part.
Yeah.
And small test. And we can see we're right in the upper lobe, superior lobe, anterosuperior lobe. And I'm slowly trying to pull back and deploy the device. It's a little canted. But I don't think I can do anything about it. So give me some contrast. I mean, it looks quite good. I'll take one more attempt. If not, I'm just going to keep it there. I'm capturing the device. And then testing here. Okay. And it's slightly better tilt. Okay, so let's go to every's field. So it looks nice to me. I'm going to do a tug test.
Okay, tug test. Go ahead.
Yeah. Jenny? Inject. Yeah, it's very stable.
Looks stable on echo for what it's worth.
Right. So now let's look at, go.
You're going to take some measurements?
No. I would actually go to real time, not 3D, because I want to do color.
Okay, sure.
So I would just go to.
You don't want me to just get the measurement here
like
first? Okay.
No.
All right.
So let's go back to real. That's it. So let's get a nice image there and see first with color. We're nicely at the level of the circumflex, and there's no flow around it. Now let's measure that.
You see that it's here harder to get a true side view.
Okay. That's okay. Okay.
See,
Freeze
some of
that.
this looks on FOSS. It looks close enough, I guess.
I mean, if you want, you can, yeah, you should be okay. Yeah. You can measure that. All right.
23.
23. Explain that. And you could put a color. This is actually not a bad shoulder, actually. Not as big. This is quite good, actually. Put color on. Okay. He's first measuring. I think he is over measuring here. Okay, good. 23. Oh, I like that very much. And you can see there's no color flow in the inferior aspect.
And
So
you can
this,
decrease the scale to really accentuate it, but
yes, and even that, and this
it
is the
doesn't show
most
anything.
important view. He's doing in the 135 and showing that there's
On
no
both sides.
flow,
Yep,
no flow on
nothing.
either side. Okay, that looks great.
Here's 0 and 90.
Let's do 0 and 90. So 0 looks very good. And he's taking a measurement. That's really nice. That's 23. So it's not super compressed. 24. Is that acceptable? Okay. And let's put color.
The 90 looks like also good.
Price is not as compressed, but I think it should be okay. And it's very stable. And there's no color flow. So I'm actually going to, based on these findings, I think it's reasonable to deploy this device.
I think
right?
we meet criteria. Yep.
So there's no flow, and I'm just going to unscrew the device over here. So the 4 criteria that we fulfilled, this is a beautiful picture, is position, anchor, size, and seal. So the position is very nice. It's at the level of the circumflex. We're going to do one angiogram. Yeah. Just the last picture to show everybody. And you can see that there's a contrast going through the device, but not around it. So it should only be 2 cc. Not a PCI. All right, yeah. So it looks like, you see, just when we do it, we just inject like this. And it's, as you can see, it's just filled up quite good. So the procedure is done. We're going to take out everything over here. And I'm just going to do the figure of 8 stitch over here. So can you show the groin? And I've got a per close in the groin. I'm pulling out the sheet, and I'm just going to pull the per close. And if I need, I may give an additional figure of 8 stitch. So I just pulled it out. The venous hand is good. There's not much of bleeding in the groin. Let me just pull this out. And okay. Yep, there's no bleeding at all. So I think it should be okay. Yeah. No, it's okay. So I'm just looking at the groin if there's any bleeding at all. Yeah, there's no. So with the single figure of 8 stitch, sorry, it's actually single per close, it's all fine. We do the last images. Gabriel, do you want to show the last images? You want to show the residual ASD if there's anything left?
Yeah, you just want to make
You
sure
want to
it's
show there's no
left to right.
fusion? Yep. And maybe you should just show one 3D end face.
And I did, yep. While you were busy with your
Okay, great.
axis, I did that.
That's good. I think I've done it once before. Thank you. Thank you, Ralph. Ralph is one of the senior techs over here. He's an outstanding person and an outstanding.
Yeah, there you see it's just a small left to right ASD right there.
Yeah.
And we just make sure there's no effusion.
So I first want to thank everybody.
And there's
in
no
this room.
effusion.